Good afternoon, everyone. Thank you for joining us for day 2, the afternoon session of the AHI Leadership Summit, Uniting the Future of Population Health and Virtual Care. My name is Courtney Shaler, and I manage the Adirondack Rural Health Network for AHI. I'm proud to welcome you to this afternoon's session on behalf of our CEO, Eric Burton, our AHI Board of Directors, and the staff here at AHI. This afternoon's session, Partnering with EMS to Improve Health Outcomes, is presented by Mark Spezio of the Cambridge Valley Rescue Squad. Before we go any further, I want to take a moment to thank our past sponsors. We've been doing this event for 12 years, and we wouldn't have made it as great as it has been without the help of these business partners. We encourage you to chat with them and visit with them, hopefully when we're in Lake Placid in person next year. We're just going to do a few best practice tips to help you get the most out of the session. Please confirm that you're muted and your video is off upon entry. To avoid audio issues, please choose either computer audio or phone audio. Using both may result in an echo on your line. For optimal viewing today, we recommend using side-by-side mode. To activate side-by-side mode, click on the view options at the top center of your screen and choose side-by-side mode from the drop-down. I also suggest you click on speaker view. That will allow you to see both the video and the slides at the same time. We encourage you to use the chat freely to submit all questions, technical issues, and any comments you'd like us to share with our presenters. AHI staff will be monitoring it, and we'll make sure we get to every question. If we cannot, we will connect you with a presenter after to make sure your questions are answered. Mark will present for about 45 minutes, and then we will take questions for the last 15 minutes. And last but not least, all presentations are archived and will be available on the AHI Conference's website by October 9th. This will be both the videos and the PowerPoint slides. Thank you very much. I'm now going to stop sharing my screen and invite Mark to share his.
Well, thanks, Courtney. I just got to close out of something there that popped up on my computer. One quick second here. Share screen. All right, can everybody see?
Mark, I can see your screen, yes?
Outstanding. All right, gang. Are you ready, Courtney?
I am. Take it away, Mark.
All right. Thanks, everybody, and welcome to the AHI Summit today, partnering with EMS, the EMS world to improve healthcare outcomes. I want to thank the folks at AHI and the Rural Health Network for giving me the opportunity to put this program together and to chat with you all today. Certainly would have been much nicer in Lake Placid, but you know, this is what we do. This is our reality, so we're going to have fun with it. I'm going to try to rifle through these to give everybody an opportunity to ask some questions at the end and go from there. So just a little bit about myself. It's in the handout or the information about the course itself with the presentation. Been around for a while, doing EMS for a long time, and over the last 10 or so years, I've really kind of entered into a different realm here in Cambridge and in EMS in general, and looking at ways that we can fill gaps in the healthcare system, in addition to our normal operation, which is, you know, the responding to 911 calls. So, you know, my experience is, you know, not only in EMS, but I have some experience in the.
Mark, can I just? I'm just hearing some background noise. Is someone at the station like backing up an ambulance? Is that what that is?
They are, and I've got all the doors closed. I can't.
Okay.
Yeah, they are.
Okay, I just wanted to make sure it was nothing on our line to let everyone know. I'm sure.
Yeah, no, it's just that. So hold on one quick second. I'm gonna have somebody run out and ask them to turn off the backup alarms on all of them when they come in. So anyway, my experience not only is in EMS, but I also have some background in the public sector as well, with in public safety and with local government, both on school boards and village boards and those kinds of things. So hopefully I can bring this from a perspective not only just of EMS, but from a community perspective as well. So kind of an opening statement here is, you know, the role of EMS, you know, continues to expand and evolve over time, and community paramedicine programs and alternate delivery systems and methods are really starting to grow nationally across the state and even regionally right here where we are. So what we're going to do today is just kind of take a little bit of a walk through some of those and kind of talk about how non-EMS organizations in healthcare can utilize EMS services within their community to help fill gaps in the delivery of whatever healthcare is needed in that particular region or that particular community. So again, the objectives, we have to have objectives, right? So we're going to talk about what the traditional role is, not that you guys don't know, but there's also things that we do on a day-to-day basis other than the red lights and sirens, 911 calls, that you may not know that we do, which certainly can be a gap filler. And then we're going to talk about some alternative delivery styles, including this concept called ET3. And then we're going to talk about how to develop a partnership that would involve EMS and help out overall in community health. So quickly, the traditional role of EMS, I think we all know about the 911, the emergency calls, the car accidents and the falls and the heart attacks and the cardiac arrests and the overdoses, which unfortunately continue to be a really big part of what we do on a day-to-day basis. But also our emergency 911 call base includes a lot of what may be considered non-emergency type calls, the falls which involve lifting assistance, the can you come evaluate me because I have a headache and I've started a new blood pressure medication and I don't know whether I should go to the hospital or not go to the hospital, or even minor trauma, a lot of evaluations associated with police responses, even minor car accidents. If somebody complains of anything, then they're calling an ambulance. So in some cases, what we do is we become a really mobile medical care unit. It's not just about the quote unquote saving lives aspect of what we do. I'd say that if you were to look at statistics over a year's time, probably 7 to 8% of at least our responses, and it's the same whether it's here, it's in Cambridge, it's in Queensbury, or it's in New York City. 7, 8 of them would fall into the life-threatening, life-altering responses. And then we have this big group in the middle that are, the 60 or 70%, where we say that we help reduce suffering. We help somebody that's having trouble breathing, and by the time we get to the hospital, we fix them. They're better, those kinds of things. And then the last grouping are the ones that, to be honest, if they called an ambulance, we're able to provide a community service. But if they didn't call an ambulance, somebody probably would have been there to help them out. Then another role that we have is routine transports. And these are scheduled non-emergency trips, whether it's bringing somebody home from an admission at the hospital back to a nursing home or back to a residence, or transporting a patient that's bedbound from a nursing home. We took a gentleman today from a nursing home here in the county to a hospital, an out-of-state hospital, because he has to get labs drawn. You might say, why does he have to go by ambulance? Well, these are labs that need to be evaluated or need to be spun really quick after they're drawn. So he has to actually get to the hospital to have those done, and he has no other transportation. He's bedbound, he's bariatric, and so we do those kinds of things. The other thing that EMS does a lot of that you might not hear about are event standbys or event medicine. The state has some requirements that any gathering over 5,000 people, you have to have a medical plan, which must include EMS. So certainly things like concerts at SPAC or at the Pepsi or the Times Union Center, those kinds of things, there's an EMS team that is there. But even some smaller events, whether it's the county fairs or, large athletic events, there's generally EMS is there and part of it. And then for a long time, EMS has been involved in community education, anything from teaching CPR classes to going to the senior center and talking about recognition of stroke, to going into the elementary schools and just, making kids familiar with what an ambulance is and how to call 911 and those kinds of things. So one of the things with the current delivery model is, according to the Centers for Medicaid and Medicare Services, the only service that they will pay for, Medicare, Medicaid, and of course as we know, you guys all in the healthcare system, the only thing that the other insurers will pay for as well are based upon what CMS makes for rules. And the rules are very simple. If you transport somebody to the hospital, we'll pay you. If you don't transport somebody to the hospital, you don't get paid. So what's happened over time, especially things with the Affordable Care Act and with hospitals not wanting patients to return, patients not being admitted, the hospitals don't want patients back, or people are living at home more and don't want to go to the hospital more frequently, or we get the lift assist type calls. So from an EMS perspective, we go to these and we have to be operationally ready to respond to these calls. But if we don't there's no funding mechanism unless we take those patients to the hospital. Some communities do supplement with tax-based revenue. There's ambulance districts or contracts with towns to do that. I will say especially in Washington County, with the exception of one of the 8 services in our county, the rest of them receive under $25,000 a year in taxpayer money, which is way less than 2 or 3% of their normal operating budget. So we have to find alternate ways to deliver service and find ways to be able to pay for that service. Before I kind of jump into this, one more thing on the traditional role, just real quick, that I think is important, is there's a lot of EMS agencies right now that are struggling. And over the course of the last 5 years in the state of New York, there's been upwards of 40 or 50 EMS agencies that have closed. None in Washington County, thankfully, where I practice, but Saratoga County, Rensselaer County, Albany County, Fulton County, Essex County, a number of agencies have closed, and primarily for 2 reasons. One, finances, and number 2, volunteerism. And if you don't have enough money to pay staff and you rely on volunteers, you don't have volunteers, you're not going on calls to generate revenue, then you're going to go out of business. And then what happens is you have a big gap, and a big gap for those 8 or 9% of people that do need an ambulance right away. So how do we handle that? So we look at alternative delivery models in hopes that they are going to, number 1, improve population health. Number 2, they're going to be a way that eventually we can generate revenue right now, even if it's through grant systems, where you can supplement responders, you can supplement budgeting, you can get the community more involved by doing some of these programs and help the sustainability of these EMS agencies through this. So, community paramedicine or mobile integrated healthcare are the words that describe these alternate delivery models, and it's been around since about 2010. Combination of things led to it. The Affordable Care Act was really kind of the push forward, but there was a paper that was published in 1996 that really said that EMS needs to migrate from more of a public safety umbrella into more of a public health umbrella. And again, the Affordable Care Act allowed us to do this. And states that are much less regulated than New York, these programs developed much quicker and have been much more elaborate and have been doing many more things than what we're allowed to do here. However, we've seen a definite change, not only with COVID, but even a little bit before pre-COVID, with kind of the direction that our state wants to go with regard to this. And a lot of it has to do with our Bureau Director, Ryan Greenberg, in the Bureau of EMS, is very interested in getting these programs up and running because they do make sense. So the programs range from our program, which was the first in the state, which is our flagship program, is called the Community Check Program, where it's basically wellness checks. We work with a patient's primary care physician, and routinely we go and check on these folks. We do an assessment. We communicate that information back to the primary care physician, and it's been very successful. About 7% of all of our patient contacts result in some level of what we call redirection. In other words, the patient doesn't go to an emergency room, the doctor's office, or require an ambulance because of their involvement in the program. So when you calculate that into healthcare dollars, we're saving money, but we're also improving, the overall health of the individual. But then you go down to Northwell Health, which is in the New York City, Long Island area, and their community paramedicine program has specially trained paramedics with a special, with kind of an enhanced toolbox, if you will, responding to high priority 911 calls. Things that right now we respond in ambulance to and almost always take the patient to the hospital. They're responding with a paramedic with, again, this expanded toolkit, and they're treating the patients on the scene and not transporting them. In fact, less than 10% of the patients that they get to are actually transported to the hospital within 24 hours of the patient contact. So, what's nice about Northwell Health is it's a closed system. They're a payer plus a healthcare system. So they're saving internally, they're saving money and putting money back into the program. And there's a variety of programs nationally that do a whole bunch of things. But the real emphasis behind any of these programs are their grassroots, and they're developed to fill gaps in whatever the healthcare needs are within a community. So as I said just a minute ago, in New York, we definitely have to navigate through a whole web of regulations. Certainly we have to develop programs that fall within the guidelines of the state regulations, which means we can't do anything that's particularly scheduled because we can only operate in what the state refers to in an emergency situation. Scope of practice it's not limited, but it's definitely a different scope of practice than it is for RNs, those kinds of things. But certainly anybody in our state has been able to navigate that pretty well. And I will say, like I said, the Bureau of EMS has been very helpful in helping us navigate through them. And again, programs vary, as I talked about. So the focus is reducing admissions. I've been, our organization, our mobile healthcare team, which is a collaboration of 4 EMS agencies in Washington County, and we jumped on board with the district project day one. From the very first informational meeting, I guess it was the second informational meeting, we jumped on board, and we were the only EMS group that participated in district. And I'm pretty happy to think that, I feel pretty good about our data and what we were able to do did help meet all of the benchmarks that the district program did, and did very well. I think we had a small part in that, and that's actually very exciting and very rewarding. So it's kind of what we were hoping to do, and I think we've been able to do that. So alternate delivery models, the data speaks volumes. We could do a 3-day presentation on the data that's come about because of this. The National Registry of EMTs, NREMT.org, the National Association of EMTs, NAEMT.org, has an entire section of their website that's dedicated to mobile healthcare. And there's a ton of data on national programs that's available there. Our state association website has our 2019 presentations from our conference there that, again, has a number of data points there. But every single one of these programs seems to work. And the nice part about it is like with any program, I will say that, the groups that are doing community paramedicine programs are evaluating their programs, looking at what works, getting rid of the things that don't work, and then trying to build upon the things that do. We don't want to spend a lot of time on loss leaders or on programs that don't meet the benchmarks of what we're trying to get. But certainly the ones that are continuing and the ones that are successful, have an increase in patient satisfaction. We've noticed that here, and we've really enjoyed really good patient satisfaction. Not only patient satisfaction, but primary care satisfaction, improving relationships with that entire care team has been phenomenal, and families as well. We've definitely seen a decrease in readmissions. I think the district program overall showed that. Again, hopefully we had a small part of that, and certainly that translates into improved health costs. So these programs, when done right, certainly hit the AAA by far. So one of the things to transition from what we currently do and how we're paid to this concept of mobile healthcare is this concept of ET3, which is Emergency Triage, Treat, and Transport. And this is a CMS initiative. And they rolled this out just about a year ago, maybe 16 months ago, and as a pilot. And agencies had to register for or apply to be part of it. What ET3 or what CMS looked for was to use some rural, some suburban, and some urban systems across the country that would represent a certain amount of population of Medicare patients, and they would award these bids to allow these organizations to enter ET3. There are 3 primary things that organizations need to be able to do to participate in ET3. One is they have to have access to telemedicine or direct medical control. Telemedicine was supposed to be video to start with, but even in the larger metropolitan areas, they were having difficulty with the actual visual component of it. So I'm pretty sure that's been reduced down to just telephone communication when needed. Their area had to have treat and release protocols. In other words, a set of guidelines. So when you went to somebody's home, this is what you did, and you treated them, and if they got better, you didn't transport them to the hospital. And then the last thing is you had to have alternate transport destinations, things like urgent care, crisis center, mental health crisis centers, maybe 24-hour dental centers, those kinds of things. So we actually had a number of agencies around our area in the Capital District that got approved. Town of Colony got approved. Malta EMS got approved. There was definitely some downstate, Northwell Health, Empress EMS down in Westchester County were approved to participate in this program. And the idea is they were going to get paid the regular Medicare reimbursement rates for doing these things. They just wouldn't bill for mileage, which doesn't make sense. Obviously, they're not transporting the patients to the hospital, but they would be paid everything minus the mileage. Where Medicare wins is on the end of the emergency room, because these folks are being treated at home by EMS, they're then not going to the ED. So even by saving the mileage is one component, which generally isn't, it's kind of a drop in the bucket. But where they're really saving money is on not having the ER expenses that are associated with these kinds of things. ET3, there was a big push to implement that immediately during COVID because we were doing so much treat at home and not transporting patients. CMS actually went the other direction, and they held off on letting it be implemented until after the first of the year 2021. So there's still a pilot. It's still going to be piloted, but my guess is because the data is so convincing that this works, that very shortly thereafter we will be doing ET3. Everybody will be doing ET3, and you'll see a lot more of these programs develop. All right, so enough of that background stuff. So what are we actually here for? What can EMS do for you type of thing? I've talked a lot about gaps. And one of the first things that really should be done before getting EMS involved or even bringing EMS to the table initially is to ask, what gaps do we have in our community that we can use somebody that has medical training, that's in the community every day, that probably has some time. What can they do for us? How can they fill that role? Where can we plug them in to help us meet the goals of our community? In some cases, it may not be just a healthcare system, like a hospital-based system or something like that, or it may not be just another community-based organization. Maybe it's time within a community that a few community-based organizations and maybe the primary or the secondary healthcare system in the area and EMS and maybe mental health professionals, if they're there, get together and say, let's have just a meeting. Let's just get together. We'll Zoom it. We'll do it in person, whatever you want to do, and say, wow, we've got some gaps in our community. How can we start filling them? Because I think to some level, even though we play in the same farm, we still tend to at night go and sleep in our own silos. So if we can kind of knock those silos down and realize that there's other healthcare providers within our community that can do some things, I think we're going to be better off overall. And that's kind of where we've landed, within our part or our geographic areas. When there's a healthcare need, we want to be part of it. And to some level, our steering committee for our mobile healthcare system has developed into really a community health committee, where we look at what's going on in this part of the county, and then with all the organizations that are represented, we can decide, geez, who can fill those particular gaps. And certainly having somebody like AHI involved in this, where you have somebody that can see it from the 100-foot version, it helps connect those dots and helps network to fill those things. EMS can be a great partner. Again, you've got folks out there with some pretty extensive medical training. There's hospitals, as an example, in Canada that staff their emergency rooms after hours with an RN and a paramedic. Why? Because they have kind of same level of training, but different scopes of practice. A paramedic can intubate a patient, where a nurse can't intubate a patient. A nurse puts catheters in, Foley catheters, and can do a different type of assessment, different type of diagnostic, where a paramedic is inserting interosseous needles and interpreting cardiac rhythms and 12 lead EKG. So the level of training is similar. The type of training is a little bit different, and they can complement each other very, very well in a lot of situations. So what are some ideas out there? So I talked a little bit about our community check program, and certainly when COVID started, we said, whoa, we need to back off on that. We shouldn't be sending people into other folks' homes to do these wellness checks, because it's not only going to take one COVID and wellness goes right out the window. So it protected our folks and it protected our participants. We did try to check in with most of them, by the phone, and just make sure they were okay and do those things. But what was happening, one of the things we thought about is, everybody went to telemedicine visits. And, as Katie had talked about last week with her summit, and, lots of folks know, the amount of telehealth visits has skyrocketed. So here's one thought. And we've actually done a couple of these, and they've worked fantastic. We have technology. We have computers like the one I have, or we have computers in our ambulances. They have all the information. We also have mobile, MiFi's, hotspots. How about we take our computer and our Wi-Fi or our Wi-Fi to somebody's home that doesn't have a computer, doesn't have internet access, and we can sit down, hook that all up for them, talk to the doctor's office, get the access information, and allow the patient and the physician to actually have a true telemedicine visit instead of just talking to them over the phone. To enhance that just a little bit, and the ones that we've done, we've gone about a half an hour early and done an assessment where we've taken vital signs, we've, just say, are you taking your medications, do an environmental assessment, do those kinds of things. So that way, when the doc gets on board or the provider gets on board, we can provide them with all that information. So they know what their patient's blood pressure is. They know if they've been taking their medications. They know if there's any type of environmental or social issue at home. So that's worked very well. And that's something that I think can expand. And that's something that certainly the majority of EMS agencies would probably be willing to work with. Check-ins. Here's another one. One-time visits. Not everybody's going to want a community check program where we're going there for once a week for the next 10 years or the next 10 weeks. But maybe, from a primary care perspective, or maybe from a community-based organization perspective, you've got somebody that you feel is a little bit at risk. Maybe they were just discharged from the hospital. They're not getting home nursing services. There's not going to be the follow-up. Maybe you've been worried about them for some reason. Reach out to your EMS agency and say, hey, can you do these maybe this one-time visit where you can go knock on the door. You let it call them ahead of time and say, hey, look, I'm going to be stopping by. We just thought we'd check on you to see how you're doing. And just stop in and say, hi, and do a quick medical assessment. When you can't be there, whether it's, again, a primary care practice or another CBO that has somebody in the community that you want checked on, again, another great resource, and it builds that networking and builds that trust and interaction between the agencies. Labs. And we had been asked a couple of years ago by one of the healthcare systems in the region if we would go out and start doing lab draws. And at the time we said, it's a lot of work, for what we were going to be reimbursed for, which is pretty much nothing, plus the timing and the coolers and all those kinds of things. So we really didn't do it. But what we did start doing during COVID is going out and doing some draws for patients that cannot make it in to get their regular labs drawn, especially, 3-4 days before they were going to have a telemedicine visit. And I think, one of the things we talked about in our last steering committee meeting is maybe it's time to expand that. Maybe it's time to relook at that and see if there's a way that, we can provide that service and it still be a revenue generating service for us to some level. So again, that might be something, or, maybe not a routine type situation, but maybe, last minute, we've got to get this patient's labs checked. They can't make it to the hospital. We're really concerned about them. Some other ideas, required training. This goes back to the community education thing that EMS has done for a long time, but do you know of another industry or agency within your area, within your geographic area that needs PPE training? Certainly we're doing all online training now, and you can find a bazillion different YouTube videos to talk about PPE, but is that sufficient? Do you feel that you have learners that can't learn that way? Where could EMS meet in a small group, 3, 6, 10 people, depending on the space you have, and actually demonstrate how to don and doff PPE, what it's for, why it's being used, those kinds of things, and talk about hygiene and what have you. You still need to have CPR and first aid training, and I don't know of any EMS agency that doesn't have trained CPR and first aid instructors. I know you've got the Red Cross and the American Heart Association out there that in a National Safety Council that if you call them, they will send people. Here's my contention. We all like to use the word shop locally, and to some level, shopping locally can include doing your EMS agencies. They may charge, but chances are they're charging a lot less than American Heart Association or the American Red Cross to provide the same level of training. They pretty much all have the training equipment. They may even have the space to do it, so you don't have to take up space in your own facility to do it. Certainly there's some new COVID rules with how we deliver the courses, but again, might be a really good idea. Or do you have somebody that comes in? Do you have AEDs on site? Do you have somebody that comes in and checks them, even just to make sure the batteries are still good and the pads are within date? That might be another example. Hey, can we have our squad come in and maybe do that for us? And then there's other healthcare training that may be out there. One of the big ones is this concept of stop the bleed, because the data is pretty evident that you can bleed to death much quicker than you'll then you'll die from having a complete airway obstruction. So, if you're in a situation where there's any potential for bleeding, you want to make sure that those folks are trained. Again, another area where you can invest in EMS and develop some sort of a partnership. Certainly events. If you're doing a healthcare related event, include EMS. I'll be honest with you, sometimes we seem like the forgotten part of the healthcare system and of public health. If you're doing some sort of a symposium, or you're doing some sort of a job fair that involves healthcare, invite them. Invite your local EMS. If they don't want to come, then shame on them for not participating. But certainly, it's worth the effort to involve them. I would also say that EMS is becoming much more of a career path. Volunteerism in EMS is fantastic, and I know right here we would not survive without the volunteers we have. We just don't generate enough revenue to be able to do what we need to do with 100% paid staffing. But by the same token, most everybody in EMS knows that a true volunteer-based organization is not sustainable in our particular geographic region, pretty much anywhere in New York. There's just not the workforce at a volunteer level to do it, and we're so far away from hospitals that we need to have higher level training to be able to do it. And it's really hard to get paramedics to volunteer, to be honest with you, just because of their training and all the things they go through. So including them at job fairs is a really good idea. And then innovations. Maybe there's something that's not on this list that really should be. And how do we know that? Because somebody has an idea. Somebody just has read a trade journal, or somebody has seen a post on social media or something of that nature, and they say, wow, let's fill this gap. How can we do it? Geez, maybe EMS can help. Or maybe they have somebody that's done this before or done something similar to it. So another question that's asked, well, geez, aren't you guys busy enough? And yes, I mean, during the height of COVID, no, call volume dropped upwards of 40% nationally, and even, around the same numbers were felt here locally. And not only did call numbers drop, but the number of people that went to the hospital dramatically dropped as well. So we did kind of sit around and twiddle our thumbs quite a little bit. Certainly we've seen the COVID rebound, and the acuity level's gone up a bit because people haven't been going to the doctor and taking care of themselves. However, there's still room for us to grow as a business, as a public health organization. There's certainly room for EMS to engage with the community, be part of the community, and be invested in it. So there's 5 reasons why it's good to engage and partner with EMS. 1, we're part of the community. There are examples of commercial EMS agencies, or fire-based, municipal-based agencies. When you get into like city of Saratoga, the city of Glens Falls, you get to Albany, where you have a commercial-based system. But certainly, whether it's the municipal fire department or commercial agency, or the organizations that we find the most common around here, which are the non-for-profit kind of combined volunteer paid staff groups, we're still community-based organizations, and we're part of the community for a lot of reasons. There's also that, the untapped potential, that expertise. They could be surprised at how many folks in EMS bring something else to the table as well. But even as EMT, which is kind of the entry level training, it's 160 hours worth of medical training. So certainly there's potential there to do some things that maybe you just don't have time to do, where EMS can partner. Sustainability, I talked about just a minute ago. It's kind of reimagining what we do, reimagining our business plan so that we can remain sustainable. So yeah, we're busy with 911, but maybe so that we're able to respond to the 911 calls, maybe we need to do some of these other things so that we can build a model so we have enough people that, hey, look, we can always come off of doing something that's a non-emergency to respond to an emergency call. But if we have to scale back and only do emergency calls, we may not have the people to go to that second or that third or that fourth call. I talked, number 4, I talked right in the beginning about kind of the transition from public safety to public health. And I think that's a role that's going to continue to expand. COVID certainly has accelerated some of these types of things, but certainly responding from, moving into a public health world is important. And I think there's the flexibility of EMS is important as well. We respond to emergency situations all the time. So, I have to say, we're pretty good under pressure. And when something, curveball's thrown, You know, we hit about 333 with curveballs as opposed to the league average being like 250 or below. So I think we do pretty good when those things happen. And there's enthusiasm. I'm going to tell you about a real life case study here momentarily, but there's a lot of enthusiasm for what we do, and a lot of enthusiasm for bringing it to the next level and being involved in public health as well. So how do you do it? Again, decide what you need. You know, look at the gaps, and then reach out to your local EMS agency. You know, stop by the station, call their chief, call their captain. You know, they will want to know how it's going to benefit them. And, you know, it doesn't always have to be dollars. It can be all kinds of different partnerships. You know, I love bartering. You know, hey, look, if you can, we can do this for you if you're able to do this for us. You know, maybe you have a physical space where you could conduct training, but, you know, in that EMS agency, they're just doing it in the, you know, the back room of the ambulance garage. They don't have a lot of room to do it. Maybe you could say, well, geez, once a week or once a month, we can let you use our space for training if you can do this for us. So there's a lot of ways, but, you know, present it so that there's going to be a benefit, and even a good public relations benefit sometimes is worthwhile as well. So if that doesn't work, your local agency doesn't seem to be involved, but you really think you have a need, then go to the next level, because there may be other, you know, just because your home agency is not the agency that wants to participate, there's other agencies that may want to and still have the legal authority to do so. As an example, our agency here in Cambridge, we have operating authority for all of Washington County. So, you know, let's say the organization that covers a town in the northern part of the county doesn't want to participate, they could contact us, and, you know, one of our collaborating agencies would certainly work to help them out, and maybe we could bring that home agency along and kind of, segue them into doing EMS. So there's county EMS coordinators in each county, and in our regional councils, which are, you know, there's 17 of them in the state, and certainly their executive directors can help guide you in the right direction as to where to go. Mountain Lakes, that's the one that's got the little graphic there, covers Washington, Warren, Essex, Franklin, and Clinton counties. So I will say down here at the bottom, EMS, we're horrible about advocating for ourselves. You know, we don't lobby well. You know, we're getting better. But a lot of times we don't go out and say, hey, hi, how are you? We'd like to help. So to some level, you know, reaching out if you think that there's a need there would be helpful. All right, so I'll wrap things up before we turn this over for questions. Case study, hot off the press, super excited about this program. We started it about 10 days ago, and this is a you know, trailblazing innovation. Give you a little bit of brief history. We've always had a good working relationship with our school district here. It's a K-12 building, central school district. Census generally runs between 800 and 1,100 depending on the year, depending on who's moved in, who's moved out. New superintendent came into the district a year ago. Met with them just to get to know each other. Very systems-oriented type of guy. And again, we developed a kind of just a neat partnership. We have 4 ambulances. We have 3 ambulance bays. So in the wintertime, we need to store the 4th ambulance someplace where we can get to it. The school is a quarter of a mile from here, if that. So we made an agreement to store one of the ambulances in the bus garage. Good access, nice to do. In exchange, you know, which we've always done, we stand by at the football games for them. Little contract, 1 page, done, over with. Everybody's happy. So when COVID was going on, obviously towards the end, schools reopening, I was talking with a colleague of mine from Westchester County about another program we're doing, which we actually are developing, working with the State Bureau of EMS to allow EMS to be able to conduct COVID testing, which we think will also be a game changer. But that's a whole different conversation. But anyway, I reached out to the superintendent and said, hey, look, I know you're reopening. Is there anything that we could potentially help with? Make a long story as long as humanly possible. No, I'm kidding. Okay. He reaches out to me and says he's going to talk to his administrative team and to his health team about it. He gets back in touch with me a few days ago, or a few days later, says, let's have a meeting. We have a virtual meeting. And these are the things they would like. You know, number 1, they would like 2 EMTs on campus between 7:30 a.m. and 9 a.m. to help with screening, that they have temp scanners and they're going to have aides, but they would like a medical personnel there to assist. Number 2, they would like one of the EMTs to remain on campus for the entire day to help out the 2 nurses. There's 2 nurses, there's no aide. Their secretarial staff is the elementary secretary. That's who helps them out. So based on everything COVID and all the work they were going to need to do, they asked to have an EMT on hand to help with all things medical. Number 3, they're required to do bi-monthly PPE and COVID symptom recognition training. They asked if we would take that responsibility over, to take it out of the responsibility of the nurse, one less thing that she has to do. And number 4, if and when it's ever approved that we can actually do COVID testing, that we would make a place someplace that we would be able to test or obtain the samples is basically what we're doing. We're not analyzing it, obviously, but obtain the COVID test samples, and which would be huge because we have an urgent care center that's in the same parking lot here. Their testing is so limited, they're only doing symptomatic patients. There is one CVS in our county, which is about 20 miles away to do testing. Otherwise, everybody's going out of the county to be tested. So they're long trips, and certainly there's a lot of kids. So we sat down, we worked with the school attorney, we developed a contract, we came up with a price point, and we're live. This thing is actually working. We have a EMT or a paramedic in the school from 7:30 to 2:30, 3 o'clock every day. We're doing things from, running ice packs out to the playground, to watching kids that have been put in isolation until mom or dad show up, to just doing anything and everything that the nurse is requiring us or asking of us to do. The response to it has been overwhelming. I took an EMT over today that hasn't done it yet. And we just walked through the halls quick, just he's not from our school district, so really didn't know the building. And the teachers, the staff, the aides, the administrators, even the kids waving, they are super happy that we're there. And to be honest with you, it's where we negotiated a price point is very helpful. It's a good spot for us. And we also wrote into the contract, we get buried with calls. Certainly they're on the 3rd ambulance out. But they can leave to go on an ambulance call, which provides us backup protection for our district. So it's a win-win from a public perception standpoint. This is a huge win, and hopefully it's a model that can be used in other places. So I am going to stop on my presentation. Again, I want to quickly thank everybody for taking the time today to chime in, and thank Courtney and her gang for inviting me. And ask away.
Okay, let's see, Mark. There's a question from Crystal. Do you know the reason volunteerism has declined?
It's a combination. One, the training is pretty extensive. An EMT course is 160 hours, which means 2 nights a week for 6 weeks, or 6 months rather, just to become certified. And then there's recertification. And then an ambulance call, depending on where you are, certainly if you're close to the hospital, it might only take you an hour. But from where we are, we go on an ambulance call, there's no guarantee you're going to go to the closest hospital. If we have to go to take a patient to Albany, you're out 3.5 hours. So it's a combination. And I think in general, people just don't volunteer. I will say nationally, COVID has really hurt the EMS workforce. After 9/11, everybody patriotic, let's go, let's kick some tail. Everybody was rah, rah, yay, yay. Now nobody wants to wear an N95 in the back of a bus or back of a metal enclosed area for an hour and a half, and then have to be decontaminated and have to worry about bringing it home to their kids. So that's another.
Okay. Thank you, Mark, for answering that question. A question from Paul. Do you think EMS can expand to support requirements placed for ET3 or asks like virtual health, labs, et cetera, in both rural and urban areas? Follow up to that, do you think that this would put volunteer agencies at risk? And I know you did touch on this a little bit, but I think Paul wants a little more of that.
Yeah, I think so. A lot of it depends on the individual agency, or the real emphasis right now, the real direction that nationally, the state, especially New York State, and regionally, there's got to be partnerships. EMS agencies need to partner together. They need to. The consolidation is a big thing that's out there now. There's a lot of talk about that. There's a lot of talk about partnering, collaborating, whatever word you want to use to be able to do it. So putting agencies at risk, my guess is it's not going to put an agency at risk that's not already at risk. The agencies that are going to participate are the ones that are looking to expand, to reimagine their business model, and this may be the direction to help do that. certainly there are agencies that are really are at risk. And as I said, the true volunteer model has been shown that it's really not sustainable. Unless you're in a super rural area, or there's a great example of a rural agency at one of the big communities in Florida that's an over 65 or an over 55 community. They have an ambulance service. They have 200 volunteers. There's 10,000 people that live in this community, but they don't have anything, they don't have other life things to do. So I would say it really depends on the agency, and if they're not at risk now, this isn't going to put them at risk. This is actually going to help build them up.
Okay. Jessica had a question. You mentioned the need to fill in the gaps and not be siloed. Do you find the EMS services have been requested to go in a person's home or a care facility when instead perhaps a social worker or a mental health clinician would have been better suited to attend the call? If so, are there future plans to address this situation?
So that's a great question. And actually, one of my to-do bucket lists is to reach out to our county sheriff, who just happens to be also the president or the chairman of the state sheriff's association, which is kind of nice. I think there's going to be some big changes in the way we respond to behavioral health emergencies, both us and law enforcement, and including a social worker or a more of a clinical team approach to that, I think would be important. I think enhanced training of EMS providers to identify areas where social determinants of health are really the biggest reason why we're in there, and maybe having a social worker go and participate. And I'd like to see it as kind of a team approach, because I do think that there's usually some underlying medical thing that goes on. But I think that by increasing this dialogue, like what we're having today, or like my involvement in this RIP, certainly has improved my understanding of my networking. So knowing what services are out there. So the social work knowing that what EMS does and how it works, and vice versa, EMS knowing what the social services aspect does, I think is a win-win. And I definitely think being able to bounce, bounce referrals back and forth, or those kinds of things, absolutely. The behavioral health thing, I think, is going to change a lot in the next 4 or 5 years.
I agree. I also think too, Mark, although you didn't touch on it a lot, the work that we do on the Mobile Healthcare System Steering Committee really does speak to that. And that could be a whole separate presentation, really, that cross-sector collaboration.
Absolutely.
All right, I got more questions. Are you ready to keep going?
Yeah, absolutely.
All right, Crystal has another question. How is the assessment for mental health or special needs interventions being addressed and incorporated into emergency medical response? Is there anything built into the 911 system to identify those high-risk calls, possibly using address or cell phone numbers of call origin?
So if we know and whether it's EMS, police, or somebody else that knows that there's a potential for behavioral health problem or crisis at a particular location, we notify our county communication center to have those particular areas flagged, so that we know going into it that there may be a safety related issue. Still the model here is for behavioral emergencies, police are dispatched, EMS is placed on standby. The New York State mental health law is pretty clear that those patients that don't present with a medical problem, although behavioral health I know can fall into that concept of a behavioral problem or a medical problem, we're talking about diabetes or trauma or something like that. It's the responsibility of law enforcement to transport them. And in New York, it's truly, if you go by the letter of the law, we're not supposed to restrain people physically, even with soft restraints. And that it's tough, because I've had my wife got injured severely in the back of an ambulance as an EMT because of an intoxicated, overdose behavioral health patient. So we're really kind of on the fence as to I think it needs to be a team approach, but nothing's changed yet. It will, but nothing's changed yet.
Well, and I will say too, later on this week, we do have a law enforcement diversion program that our folks from mental health in Essex County are going to talk about. So we might be able to follow up with this participant and suggest that they check out that program as well.
Great idea.
Okay. A question from Dixie, who's also a summit presenter later in the week. Addressing mental health as well as medical health makes you a valuable safety net asset to support policy work. Do you participate in police calls? Your story about the strong positive reception from kids in the school just adds to the value of your presence to de-escalate situations.
We do respond with police. I mean, to certain police calls, certainly we do, like the mental health ones I just talked about. But, again, if they get there and determine it's not a medical concern, our involvement is staying a block away until the scene's secure, then we go in. But we respond with the police on lots of calls, obviously overdose calls, which are quite frequent. Law enforcement is there. They respond with us to cardiac arrest calls. So we do have a really good working relationship with law enforcement. And I do think, this behavioral health response, because of the times that we're going through is definitely going to change. There is no doubt about it, how we respond to those things. I will say that in EMS here, we do chemically restrain folks. And I think, is a big to-do in Aurora, Colorado. One of the medications that we carry, our service carries here, is ketamine, and the city council in Aurora has forbidden ketamine be used by paramedics for sedating dangerous patients because they had a bad outcome with a patient. And the way I look at it is, I don't want to get beat up in the back of an ambulance. I mean, it is a safety thing, and I think that, and I'm going to throw myself out there, and I know this might sound political, and I try not to be, but from a reality standpoint, no, it's not going to be that political, Courtney. Don't worry. But, a lot of these mental health responses are safety concerns. These people can be unpredictable and can be violent, and I know we need more training and de-escalation, but I've de-escalated patients before on the scene, and 5 minutes away from the hospital, they get really ornery in the back of an ambulance, and you don't have a lot of room and a lot of safety. So we've got to come up with better solutions.
Okay. And I do think what you said earlier about how I think that what we're looking at for behavioral health and mental health and that cross-sector collaboration is going to be changing in the next few years. It already is.
Yep.
Mark, do you have, we have another question. Let's see. What mental health trainings do EMS / paramedics receive to address mental health and behavioral health calls? Do you have a relationship with your local mental health agencies to receive support from them on treating individuals who are in crisis?
So it's not extensive. I'll be quite honest with you. As far as behavioral health, at the EMT level, it's a chapter in the textbook. It's probably a total of maybe 3 hours worth of textbook and lecture material, and it mostly focuses on some de-escalation techniques, as well as identifying the one thing that we are the most concerned about is excited delirium, because excited delirium truly is a medical emergency. So we want to make sure that people recognize that as opposed to some other medical emergency. Once you go up to the paramedic level, it's 8-9 hours worth of education. At the paramedic level, we also spend clinical time in both the ED crisis unit, an 8-hour rotation there, and a 4-hour rotation in the lockdown units, the inpatient psych centers, especially behavioral health units. Behavioral health units. I did mine at Albany Med, which was truly an eye-opening experience. And then it's continuing education. We have to have a certain number of continuing ed hours during every certification cycle. We do try to get at least, and again, it's agency to agency specific. We try to put all of our folks through a program called EMS Safety, which includes, it's an 8-hour program, which includes about another hour worth of de-escalation and safety tips and dealing with that. But certainly we welcome that. One of the things I do find is there's not a lot of, so when we post, continuing education and those kinds of things, you don't find a ton of EMS providers that that want to go. They'll get their minimum requirements for the recertification, but to get that next level of training. Again, I think this is going to be part of a package that goes with how we respond to mental health emergencies going forward. So I will say though that this response to mental health emergencies, it's not going to be an alternate delivery model, because they still fall into our regular 911 responses. That's kind of like an all day, every day type of thing. This isn't something that's in the alternative delivery. These are things that are part of what we respond to as our normal routine course of action.
Right. And I will say that the Adirondack Rural Health Network, we have done a mental health first aid training for EMS, and that was well attended. So it might be something that you and I might want to talk about bringing back in the future as well.
Absolutely.
All right, Mark, I don't see any more questions. Do you have some closing thoughts you would like to share with the group?
Yeah, I think that, number one, thank you. Anytime I get the opportunity to kind of promote EMS is a good thing, especially promoting it outside of EMS. As I said, I think EMS is as a bit of a forgotten partner in public health. Definitely not a forgotten partner in public safety, but definitely in public health in general. So definitely like to promote that. And reach out. At the end of the day, my contact number is there. If you don't know how or don't know who to contact or reach out, or you have an idea, shoot me an email, shoot Courtney an email, she'll forward it on, and we'll get there. But kind of we're all in this together, and certainly I've learned a lot, with this whole disrupt and networking and things, and we can only improve public health more by partnering and engaging, and so I think our future really depends on the partnering and engaging with other healthcare professionals. So thank you all very much.
Thank you so much for presenting today, Mark. It was excellent. It's like sitting at a fireside chat. You're just kind of hanging out with us. So you're a great presenter. We'll have you back another time. This is your second summit presentation. So thank you everyone for coming this afternoon. Tomorrow is day 3. We have a 10 a.m. and a 2 p.m. session. Same thing on Thursday. And then Friday we have a 10 a.m. session. Tomorrow we kick off our 10 a.m. with the Rural Health Champion Awards. Thank you, everyone. Have a great afternoon.